Welcome back, our fans. Post-thyroidectomy complications. Introduction. Surgery of thyroid. Advantage. 1. Rapidly effective. 2. Low incidence of recurrence. Disadvantage. It is a dangerous procedure. Serious complications. Indications. Failure of antithyroid drugs. To remove benign or malignant tumors. To release the pressure effect over the trachea. Social or economic factors. Nodular toxic goiter. Special considerations. 1. Thyrocardiac. 2. Pregnancy. Thyroidectomy is usually preferred as there is little risk to the pregnancy if the operation is done in the second trimester. 3. Exophthalmos. Surgical management. Preoperative preparation. 1. CXR. 2. Indirect laryngoscopy. 3. Full blood examination. 4. Sedation. 5. Drugs to make the PTU thyroid: carbimazole, propranolol, Lugol's iodine. 6. Check Ca+. 7. Prophylactic AB. Surgical approach. A subtotal thyroidectomy is the standard procedure. This operation involves excision of all but 5 grams of each lobe and all the isthmus. Why? To preserve laryngeal nerves and parathyroids. Complications. Complications can be classified into immediate, 0 to 24 hours. Early, 1 to 7 days. Late, 1 to 4 weeks. Immediate complications. Hemorrhage. Respiratory obstruction. Pneumothorax. Air embolism. Recurrent laryngeal nerve paralysis. Hemorrhage. An unrecognized or rapidly expanding hematoma can cause airway compromise. Arises from cut surface of the thyroid. Blood vessels. Presentation. Neck swelling, neck pain, and/or signs and symptoms of airway obstruction, e.g., dyspnea, stridor, hypoxia. Evaluation. Physical examination. CT scan, US. Treatment. Immediate opening of the wound and evacuating the clot, pressure applied at the wound. Patient is then taken to OR for ligation again. Respiratory obstruction. Most commonly due to laryngeal edema, which is most commonly due to tension hematoma. Can happen without hematoma, due to trauma to larynx by anesthetic intubation. Recurrent laryngeal nerve paralysis will not cause obstruction unless there is laryngeal edema. Treatment. If releasing hematoma does not relieve obstruction, trachea should be intubated. Steroids to be given to release edema. Tracheostomy is rarely necessary. Pneumothorax. From pleural injury during removal of a retrosternal goiter. It is a rare complication. Mediastinal emphysema may also happen, but it is even rarer. Treatment. Intercostal tube drainage to an underwater seal. Air embolism. Reported due to major vein injury. Treatment. Any injury to veins should be recognized and sutured. Recurrent laryngeal nerve paralysis. May be unilateral or bilateral, transient or permanent. Injured from bruising, stretching, ligature or division. If one nerve is damaged, the vocal cord in this side lies motionless and the voice is weak and hoarse. If both were injured, glottic space is narrowed and stridor will develop. It could be transient paresis post-op. Recovery takes place after days, weeks, or months. Treatment. Prevention. At operation, nerve is sutured with fine sutures. Tracheostomy might be necessary. ENT consultation. Early complications. Hypoparathyroidism. Thyrotoxic crisis. Wound infection. Hypoparathyroidism. Due to removal of parathyroids or infarction through damage to parathyroid end artery. Most cases present 2 to 5 days post-op. Could be delayed to 3 weeks. Patient will present with signs of paresthesia and neuromuscular irritability, Chvostek. First line of treatment. Prevention. Avoid removal of parathyroids. Avoid infarction. Section. Treatment. For minor hypocalcemia, calcium gluconate tabs daily. For severe hypocalcemia, tetany, 4 calcium gluconate is given. Thyroid storm. This complication was responsible for death post-thyroidectomy. Nowadays, with adequate control, it should not arise. Signs include agitation, tachycardia, tachypnea, fever and mental disturbance post-op. Management. Estimation of thyroid hormones. Symptomatic and supportive treatment. Carbimazole. Lugol's iodine. Beta blockers. Sedation. Wound infection. Happens if precautions were not taken. In patients with COPD, because of disturbed lymphoid tissue at the root of the neck, infected hematoma may occur. Treatment. Antibiotics. Abscess drainage. Late complications. Hypothyroidism. Keloid scar. Hypothyroidism happens in 5 to 10% of patients post-subtotal thyroidectomy. Signs: tiredness, lethargy, weight increase, cold sensitivity. Treatment. Following operations for nodular goiter and autoimmune thyroiditis, T4 supplementation is routine. Following operations for 1-Ry thyrotoxicosis, 1 year is allowed for remnants to recover. Estimation of T4 and TSH should be made every 3 to 6 months. Keloid scar. More likely to form if the incision overlays the sternum. Treatment. Intradermal injections of steroids at once and repeated monthly. Thanks for watching. Support us by likes and subscribes.